and see me. Vignesh, is it okay?
Yes, sir. Very much, sir.
Yeah. Welcome back to this cardiac session on bifurcation disease. We are supposed to have it last Saturday because micro people were busy with something. They requested us to do it this weekend. Hope all of you got the information and logged in for this. And that's why just to have a continuity, we thought we'll do it every time on the last Saturday, but this how it didn't happen. In future, we'll try to conduct on every last Saturday was what we planned. So the topic of today's discussion was bifurcation disease management. As we all know, bifurcation is another new important thing which is coming up, which all of us are interested and because there's a special technique involved in it. But before going on to the bifurcation, because I don't know how many of you remember that attended last time, we had to rush because of some other program commitment of mine. So I promised that if any doubts and things like that, we would do it. We'll briefly review our last month's presentation of a multivessel PCI flowchart. We understood after assessing the syntax score and depending upon the patient, whether it's stable or an ACS condition, we decide how to proceed further. If a patient is in acute MI, ACS is not easy to do surgeries in the acute stage. And so that's how we tend to do culprit vessel PCI and evaluate the other lesions in a staged procedure. And generally, the consensus is we pre-discharge, we do tackle the other vessels also. On the other hand, if patient is stable and has a complex CTO type of lesions, which are not amicable to PCI, probably surgery could be also considered here. But again, these lesions are, some of the multivessels also sometimes may turn out to be insignificant lesions by FFR. So you need to assess, and if all the lesions are significant, then probably you decide for multivessel PCI or CABG, depending upon the heart team approach and the patient's discussion and decision making. And if patient has associated renal insufficiency, things like that also need to be kept in mind. And the idea is to give a complete revascularization, be it surgery or PCI. That is the flow chart I thought briefly I'd mention. And I also thought I would again appraise you all on this calcification, because nowadays the elderly people have a significant amount of calcium. We became wiser with this imaging modalities, and the OCT showed a rule of fives which you need to remember. If the thickness of the calcium is more than 5 mm and the length of the calcium is more than 5 mm long, thickness more than 5 mm thick, deep depth, and more than 5 mm long, and more than 50% arc of the calcium. If all of these three is there, then he stands higher risk for a stent under expansion, and he needs proper bed preparation. If you see, if the OCT wise, if you see the image it, then if you after the atherectomy, then probably you produce cuts like that, and the calcium fractures are also seen with IVL balloon and other things like that. And then if you fracture the calcium and then put a stent, you might get a good stent expansions. So just to understand, if it is only fibrotic lesions, and like in ACS, we may directly stent it. If lipidemic lesions, you may dilate with just compliant balloons. Mild, moderate calciums, before then we were doing with NC balloons. And then the severest deep calciums, extending into the rule of fives, then that is where we do take the help of intravascular lithotripsy balloon, which is available now. And then if it is occlusive, very calcific, very critical, it can't allow the IVL balloon to go. That's where I think rotablation still holds a place, and sometimes laser atherectomy, which is just launched, also is coming to the picture. So this is how we decide the flow chart and approach to multivessel disease, and also decide on the approaching the calcific lesions. With this, I think before we go on to bifurcation lesions, can we have a brief chat questions of anybody? Next slide is of today's agenda. So can we have the chat questions of anybody? I did share actually that anybody has any doubts on this, any of this would clear. Can any of you have any questions on multivessel PCI? Any practical problems which you faced? Feel free to write to me in chat. Then we'll have some discussion. Then we'll go on to bifurcation. So it gives me confidence that all of you are listening actively and participating along with me. So please send some chat questions, so we will answer them. Anybody? One chat question from Praveen Nagala. What to be done, sir, in case of left main disease and inferior wall STEMI? This is a good question in the sense that if a patient is coming with inferior wall MI, but he also has left main disease. So generally, by and large, if the left main disease is only mild and not important, nothing is to be done. Just address the right coronary artery or LCX, which has led to inferior wall MI, and then put aggressive high dose statins for the left main disease. But if left main is also critical, and if RCA is occluded, then that is where you need to be extremely careful. That is a high risk scenario. Still, you open up the right coronary artery, which is totally occluded, and deal with left main. Left main, if it is non-flow limiting and if it is of borderline importance, then still probably you need to assess it by imaging or for a fractional flow reserve. Then that's where I think you can plan the procedure after 24 to 48 hours and pre-discharge once this inferior wall may get staged up, and then plan for the left main intervention. But if you feel left main is very critical and flow limiting even for the left side, sometimes you do see like that. One of the vessel gets occluded and the other left main could be still important. That's where I think you proceed for opening up that also in the same sitting. And sometimes this sort of situation happens more in a left dominant type of system where LCX could be occluded and left main also could be diseased. Then that's where I think you open up LCX and while coming back and also fix up the left main disease. If the left main is very critical, flow limiting, once you pass the wire and balloon, the flow gets decreased, then that's where we need to initially address the left main and then tackle further. So obviously there are ways, permutation combinations. Few of the things I have already mentioned, but that's where our experience and things like that also counts. But by and large, the approach is to deal with the culprit vessel, occluded vessel first, and then tackle the other vessels. Hope I've answered that. Any other questions? Actually, we should utilize this opportunity to have any discussions, any chat, or any other type of doubts you have. Otherwise, it looks to me you're just logged in and then doing something else. I want some more questions to be coming in, please. Feel free to keep asking any type of question, not only multi-vessel. If you have anything else also, we can discuss. Bifurcation regarding, we will have discussion after the end of this. There are 92 participants logged in. And one question. All of you are thoroughly understood everything, have full concepts of multi-vessel PCI, or enjoying high tea, coffee during the presentation. Yeah, Praveen extended the question further. In case of primary PCI, when we have such a case, placing IABP would be helpful after diagnosing TVD. Yeah, generally, if a patient has a multi-vessel disease, you could take the help of IABP if it is available. But we generally tend to put an IABP if a patient has associated LV dysfunction, and if you're also sure that there is no significant peripheral vascular disease. That is also important. In elderly people, again, when you are supposed likely to have peripheral vascular disease, then putting IABP sometimes could precipitate leg ischemia and things like that. So, but unless there is LV dysfunction associated, generally we can still get away by doing the procedures quickly, swiftly, and without IABP also. But if a patient is in cardiogenic shock, or patient has pulmonary edema, intubated, that's where I think IABP plays an important role and helps us to do the procedure properly. That's a very good question. And in US and all, where the new procedure of supporting devices are coming, then that's where people are using Impella support devices during what is called as protected PCI. Very good question, Praveen. Thank you. Suresh Kumar is asking LAD origin degree from LMCA and tortuous LAD. This is regarding bifurcation type of thing. What he's asking, left main dividing into LAD origin 90 degrees from LMCA and tortuous LAD. So if a patient has such sort of anatomy and patient comes with anterior wall MI, you have to deal with it. So obviously there could be some challenges in the course, but probably that's where you take the help of little more softer wires. That's where it helps into stent could not be taken into mid LAD. Then probably when it's difficult to track the stents, then that's where you put an extra wires and which take the help of body wire and try to track the stents. If still it is not going, then you have to identify what is the cause for the stent not tracking, whether some calcific plaque or lesion in between or the lesion itself. Then probably we need to prepare the bed with more balloon dilatations. Probably if you're done with only 2 balloon, probably you should dilate with a more bigger balloon like 2.5. What is optimal balloon size, and then still the plan. So identify the cause why the stent is not tracking. The only tortuosity sometimes it can get away by putting a more stiffer wires, like more strength wires like Iron Man or Grand Slam type of wires. But if the lesion is there, only putting an additional wire may not solve the problem. That's where I think you need to dilate and prepare the bed, and then stents will track. And still, sometimes the challenges noted. That's where I think we take the help of guideline and the things like that. But they're more useful in the chronic calcific type of settings. Generally, not in the acute MI type of situations. The God is not that cruel to give calcific lesions as well as acute MI presentations. Though occasionally in elderly people we do face that problem, but in young people it is unlikely to have such sort of difficult calcific lesions when the patient presents with ACS. ACS generally has fibrotic, softer type of lesions. Another question from Dr. Saleha Noren. In bifurcation lesion, how to decide two stents versus one stent, initial stent strategy versus positional and use of second stent? That I'm happy that you asked this question. I will highlight it, and I'm going to discuss that in today's class. We'll have this question answered. If you still have doubts after my presentation of bifurcation. Any questions regarding calcifications? How many of you have faced problems with the calcific lesions? 95 participants, I'm happy. Many of you have joined, could join, and this course is attracting a good number of doctors. And I want it to be more interactive so that we can have more learnings. We should also be learning from the questions and what we have discussion also.
Sir, sometimes during this calcification, we will see the calcium more towards on the adventitial side.
Yes.
Than on the luminal side.
That's okay. That many times it appears that calcium is too much, but it's only adventitia, and you pass the balloon, it goes easily. And sometimes you also see the other way. CT angio shows a lot of calcium, and when you did a regular angio, you don't even find a significant lesion. So all permutation combinations are possible. That is the enigma. That is the beauty of coronary artery disease, at least. Otherwise, it becomes very boring, is it not? If it always goes according to plan. So that's where we need to exercise our clinical decision-making power and do what is right for the patient. By and large, so only adventitial calcium without significant stenosis. We need not do anything but for putting patients on high-dose statin and preventive therapy. But calcium along with a lesion, then we need to be careful. And angiographic classification of calcium-wise, if they are train track calcium, both artery walls are seen on the both sides, even at still picture, that's the maximum extension of calcium. Probably you could say severe calcification. And the tran-track calcium, railroad type of calcium, seen only while motion, that probably you can think like a medium type, a grade 2 type of calcium. And then only one line of calcification seen on the artery or one of the walls. That is a sort of milder calcium in the angiographic classification, what you say. But now you have imaging, and you can see circumferential calcium and the extent of calcium, as I told just in the introduction. That's how you classify. But many other times, I agreed, adventitial calcium need not always go with the stenosis, but sometimes it could be. So we have to decide depending upon what comes in the angiography and further imaging if we have, right? Hope I've answered that question. Anybody else? Any further questions? Or shall we go to our bifurcation? I think we are 6:25. Then we'll go for today's presentation. I'm happy that some questions have come. And last time I did show one live in a box case where we had to use some special technology to open up the unexpanded stent. Can anybody respond? What was that? What did I show in a live in a box case last month? People who have attended last session of multivessel PCI, I did show one live in a box case where stent under expansion, RCA was a problem. LAD, I dilated very well, and then no problem, stent expanded well. But RCA, we dilated with the 2 mm in a compliant balloon, and then stent could track easily. But after stent went in, then stent was not expanding. At a particular point, there was significant under expansion. So we tried various measures. In the last, something magic happened, and it worked. That's what I showed in the live in a box case, which I have shown in the last class. Can anybody answer? What was that? Yeah, Dr. Ramya answered. I'm very happy. She's always attentive and gives a lot of strength and confidence to me that our colleagues take part and attend it. Probably she has also seen in the cath lab also, which we did. OPNNC balloon. So OPNNC balloon, it was actually opened at 35 atmospheres pressure. It opened up. That's how I said we need to have all the armamentarium on board before we do such complex cases. Thank you, Ramya, and Naveen also answered. Thank you very much. And we will proceed further for today's presentation of bifurcation disease. I feel probably even in today's presentation, if you have anything like that, any doubts or anything you need to discuss, probably you can raise the question in the chat itself immediately, so that we can have discussion. You can stop me anytime in between and probably intervene if you feel so, and then we'll discuss. Are you able to see my slide? Bifurcation lesions management agenda. Are you able to see this?
Yes, sir. Slides are visible, sir. Yeah.
Okay. So now what I would like to discuss in today in about 30-40 minutes before and show probably a live in a box case in this also at the end if time permits is we'll take you through this agenda of bifurcation lesions. So what is the classification of bifurcation disease? What are the various types? How the classification is involved? And basically tell you the concepts and principles of bifurcation lesion PCI. And present a step-by-step approach of decision-making process in the contemporary practice. And how we take decisions whether to use 2 stents, 1 stent, provisional stent. And if at all you have decided for 2 stents, then probably what type of stent technique we use depending upon what anatomy. That's what we will discuss. And also try to show one specific dedicated bifurcation stent which we used in L6 and OAM and LPACs. So this will be the agenda, but anytime you feel free to stop me, you can stop. The classification of bifurcation lesions, it evolved. Dukes, Sanborn, Safian, Levery, Syntax, a lot of the classifications came, but Medina classification is one which is most utilized clinically. And any classification, if you see, if it is more useful clinically, all of the clinicians will be bothered about it. That's how I think Medina classification simplified it, and probably all of us know it because it is used clinically. It helps us in decision-making process. Medina 1, the first one, indicates a proximal main branch, and distal branch is the second one, and third one, the side branch. So if you have a no side branch lesion here, only proximal and distal it is there, it becomes 1, 1, and 0. And if all the 3 are there, which is more complex, it is 1, 1, 1, 1. And suppose proximally is not there, both bifurcations, it is a lesion, it is 0, 1, 1. It is actually explanatory. And sometimes you may be confused if the lesion is only 20%, 30%, whether to label it as 1 or 0. The classification here taken 50%, more than 50% as important, because unless it is more than 50%, generally decision-making process doesn't change. That's how the cutoff of 50% is taken. So you have a very minimal plaque, then you could still label it as 0. And that's how you need to understand this classification. 1, 1, 1, this is the Medina classification. This is also Euro intervention made it very popular. And that's the same Medina and complicated. Syntax study classification also has some importance because basically it's quite easy to follow also, but I don't want to confuse you people. It is okay to remember Medina classification for all practical purposes. So why are we so much bothered and why do we have a separate session for bifurcation is, it involves complex anatomies, and then probably if you don't take care of the branches, then you could have periprocedural MIs. And after even the acute procedure is done also, there could be high rates of restenosis. And other beauty of this bifurcation is there is no one formula to act on. Sometimes they need to take decision depending upon the size of the vessels, variable plaque distributions, extent of side branch disease, and variable angulations that help us to take decision making. So these permutation combinations we need to think whenever you evaluating the lesion, and then decide what strategy needs to be followed in which patients. But by and large, the basic principles are the same. Like for any other PCI, we need to evaluate the patient in detail. Don't go just by the coronary anatomy. The bifurcation lesion in an 80-year-old male could be different from bifurcation lesion in a 35-year-old male. So patient needs to be evaluated, and we always need to check whether there are any contraindication to dual antiplatelet therapy. Recently, we had one 80-year-plus gentleman referred for procedure. He had hematuria. So we were not able to give dual antiplatelet therapy. So that's how we could avoid immediately not doing the procedure. We try to control his hematuria, identify it, and then defer the procedure. It's very important. Otherwise, once you place the stent and antiplatelet therapy cannot be given, and then the patient will have troubles with thrombosis and all problems. So probably evaluate the patient well and see whether there are any contraindications for antiplatelet therapy, and prepare the patient with loading. It was very important before to plan the procedure before clopidogrel times, because clopidogrel used to take some time for action. Probably we should need to plan next day. With the advent of ticagrelor, now it is a little more faster. And probably more and more patients are being put on ticagrelor because of this rapid onset of action of ticagrelor. And also pre-treat them with high-dose statins, and check for serum creatinine, other things like how we do it in other patients. And LV function is also very important. And if the patient has a pre-existing LV dysfunction, generally, then patients do not tolerate even if a minor branch is lost. So it is very important for us to see whether there is what is the LV function status in these patients. Suppose if a patient has a pre-existing LV dysfunction, we need to take all measures to avoid any branch vessel loss. You need to take care, everybody, but more so if a patient has LV dysfunction, he may not tolerate even the minor branch occlusions. Another thing which is also important is if you're tackling an infarcted vessel, one vessel is infarcted and other branch place is a viable myocardium. If you occlude that, again, patient could have trouble. So those are some of the things which are relevant clinically and along with the bifurcation lesion. Then plan the strategy. You need to see optimal angiographic image which produces shows both the origins of the vessels well. That's what I discussed in angiographic session. Elevated cranial view shows something, and RIO shows something, caudal shows some other things we discussed. And whichever views, there could be permutation combinations always possible. Sometimes you might see the openings of left main bifurcation. Generally, it's in caudal views, but sometimes it can open only in cranial views when the patient orientation of the vessels are different. So we need to identify which are the vessels and how the origins of both branches are seen well. And if you're planning a 2-stent strategy, basing on the bigger size vessel, probably it is preferable to take 7 French guide catheter. And if you're using a radial, probably now we have railway catheter also, which could still go through radial, but you need to decide. And always wire both branches, prepare the lesions well, and then after the dilatation also you could change the strategy sometimes. So those are the basic evaluation principles of patient as well as planning the strategy. Then proceeding further in the strategies, as said, we always should try to keep the side branch open. Though you may not have a perfect result in the side branch, and always wire any branch if it is important vessel. If you feel it is very thin, small, and not important at all, even if it's lost, that's a different story. But even if there is no lesion, it is preferable to wire the branch if it is for the bigger branch. And some instances in emergencies, things like that, if you don't have time, then if the lesion is totally, the branch is totally normal, then you could avoid. But by and large, you try to wire both branches and keep it open strategy is what needs to be followed. And only 1/3 of the lesions need a procedure. 70% we may need only wire. 1/3 of the lesions have more than 70% residual lesions with whatever strategy. This we need to understand. So you can't get a perfect result in spite of all our efforts. And in your enthusiasm to produce a perfect result, sometimes you could have some problems. As long as the flow is maintained well, so minimal residual narrowings in the branches, we tend to leave it because these patients do all right with provisional strategy. Angiographic appearance sometimes is not important. Some pinchitive appearances are seen, but if you do FFR, they generally come negative. That's why we tend to still leave mild diseases on angiography. Why we are doing that? We know that complex stent strategies, 2-stent strategies, doing it could increase the complication rate 8% towards 2.8% in one of the older BBC One study. So this is the decision-making chart. I want all of you to concentrate here. Many of you who are already well versed with this could know it, but for everybody to understand how we decide on the 2 stents versus 1 stent, some questions came. This is the main flow chart, which is very important. When you are evaluating the disease, if there is no significant side branch, you are fine. That means disease is only in the main vessel, and then side branch does not have any disease, then probably you would just proceed with a single stent strategy and then put a drug-eluting stent. If the result is good, we may not even do kissing balloons if the result is very good in the side branch with no disease. Whereas if you have a diameter stenosis of more than 50%, but still the length is not much, very short focal stenosis, then we may still get away by provisional stent strategy. I will show you, I'll explain to you further why provisional stent strategy works in this, but you need to do kissing here. And 1 stent in a main branch, but kissing in the side branch with a balloon. So that's where you tend to optimize the result. But in case, if by this approach, if the vessel side branch gets into compromise, that's where we need to take the help of second stent. Where do you electively plan 2 stent strategy? This is important. That's why it's highlighted as red. The side branch is big. Vessel diameter is more than 2.5 or at least 2.5. And the diameter stenosis is more than 50%. But the lesion length is also long. So that's where we tend to land in trouble. You can't cover that ostial lesion like in provisional stenting because the lesion length is long. So that is where you electively decide for 2 stent strategy. So hope I have answered that doubt. One is the side branch has to be big and the lesion has to be more than 50% and extending longer, preferably more than 70% lesion and long lesion. So that is where we tend to electively decide for 2 stent strategy. And then once you have decided for 2 stent strategy, then how do you plan further, whether to what type of stenting technique you need to take. I will further explain with some of the pictures later in the coming slides. But basically, you decide this depending upon the angulation between the side branch and the main branch. If the angle is narrow, like less than 70, then that's where we tend to do crush or mini crush or culotte type of stenting. If the angle is big like this, then probably you can get away by putting a T-stent. So then finally, we need to do kissing balloon and pot. Recently, there is some data which showed that pot doing or not did not matter much, but by and large, mechanism-wise, if you think pot helps. So that's the approach which we need to follow. Then I'll further try to tell you regarding some of the important tips and tricks regarding guide catheters, wires, and balloons. So whenever you're planning a bifurcation lesion, you need to have good guide catheter support, because when the balloons are going or stents are going, you need to have a proper support. Otherwise, everything systems come back and you land in trouble. So we prefer generally using extra backup guide catheters. If that is also not sufficient, probably taking help of ambulatory occasionally. But by and large, when there is osteal disease, then of left main, things like that, we tend to avoid ambulatory catheter. But most common catheters which is used is extra backup catheters, XB3 or EBU. Then 2 stent strategy when you're planning 7 French. We hardly take 8 French now because all the 7 French can take 2 stents also. Then when there's 7 French, then we tend to use femorals. But occasional patient who has fancies of radial or things like that might request you to do only radial. And we also become very comfortable now with radial because the problems of hematoma and all is gone. So we want to do radial, but still a 2 stent bifurcation strategy. Sometimes you can still get away by using everything, all new materials and 2 stents also by placing 1 stent distally into the artery, things like that. But now the railway catheter of Cardis, which has come again with a sheathless entry and has a 7 French profile, could help you in taking 2 stents also through radial. You need to be careful with guide catheter tips, especially when you're getting the balloons out and exchanging the wires, because guides tend to get sucked in and the osteal dissections could happen. That's where we need to be careful. And when you're withdrawing the balloons back, then you need to slightly unhook the catheters and then withdraw the balloons back. Some things about wires. Whichever, when you're using a bifurcation technique, whatever wires you're comfortable with, please go with the same wires. Don't take any new fancy wires when you're dealing with a more difficult lesions. Unless it is a CTO or something is different, Otherwise, whatever use your regular workhorse wire, somebody could be using BMWs. And nowadays, we use run-through in our lab more commonly, but sometimes suddenly run-through is not available. You could take any other wire which you are comfortable. Then slippery wires, generally we don't take unless you have a difficult side branch entry. And then hydrophilic coating again sometimes could create trouble while coming back from those stent struts and all that, and wires could get stuck. So unless you need a slippery coating wires, we tend to avoid it. Then always tend to take new wires in the side, especially for side branch, and because otherwise at the junction of soft portion with the stiffer portion, there could be some disturbance there, and that the wires could break at that particular point. So please try to take good wires. And to enter the side branch, probably we need to shape that wire tip in a bigger fashion. Sometimes the pre-shaped wires also come, which helps. And otherwise, you need to give a little bigger curve for a wire not to get into under the stent struts, one, and two, for it to enter the branch axis. And as I said, always wire both branches. And each of us could have our own methods to avoid wire entanglement. But probably putting a gauze piece in between the two wires always helps you in avoiding entanglement of the wire. Don't keep on changing the wires that side to this side. Whichever wire is a main vessel wire, keep it towards you. Other one, we can keep it away, and follow that strategy continuously. And your person who's assistant should be putting a torquer or something in the wire in which it is not being used. Then exchange the first wire into side branch after stenting the main vessel. This is to avoid coming out of the proximal portion of the stent. This I will show you with a case example, one of it. Rewire the main vessel with the removed second wire, preferable to have a rounded tip and to have active movement of the wire tip while entering the stent. These two steps I will demonstrate to you in one of these case examples. Many of you, even in the previous lectures, many of you used to ask, what is this business of crossing the proximal cell versus distal cell once a main vessel is stented? Then when you're rewiring the side branch, some people said proximal, some people said distal. So I think if anybody who can answer this, I think now we have crossed a century. Participants are good. And this proximal struts, distal stent crossing business, though I have done some cartoon here to explain, I want some chat things to come in, please. Because when do you prefer the proximal stent crossing? When do you prefer distal strut crossing these wires? Do you have some thoughts? Or anything strange also, it's fine. Send me chats. Let us interact more this time. I'm not wanting to just continuously me talking. I want you also to be participating in this. So when do you prefer proximal strut? When do you prefer distal strut? Please send me the question in chat. Vinod Babu said, based on the side branch angle, we decide. And Dr. Siddharth Bajaj said, mini crush, we go proximal. Vidya said, distal is usually preferred, so neocarina is well defined. Praveen says, shift of carina and proximal strut crossing. Karthik says, we should always cross through the distal strut only, except in one step of DK crush. There are some truth in every statement. Basically, I want you to understand the concept and philosophy behind this crossing. Then there shouldn't be any confusion. So why you are doing it and all is fine. But basically, if you understand the concept of how this also tells you and explains to you why provisional stent strategy works very well. Okay. So whenever you're planning a two-stent strategy, actually, it doesn't really matter which strut you are crossing. But in that also, people tend to say that you could cross proximal strut because the entry of the stent into that becomes easy. That's the only question of comfort level of taking the stents into the branch. So, but by and large, when you're doing a provisional stent strategy, distal stent strut crossing is always preferable. Why? Let us see now. So I don't know, I'm not a great expert in drawing, and there are some challenges in drawing in the PowerPoint. What I said is, this is the main vessel, this is bifurcating into two, and this is a side branch. So this round things is a stent struts. So there is a one strut here, one cell here, and one cell here, both in the side branch level only. So this is the proximal cell for this, and this is the distal cell for this side branch. Hope I'm clear. So what we did here is we had to cross from the distal cell. Okay. So what is recommendation? What is recommended is that obviously when you go into the main vessel, probably when you are taking back the main vessel wire, I'll come and show you in that case example which I show. Normally, once it is done, what do? You are supposed to put another wire in the main vessel, get the main vessel wire back, and then when it falls into the branch, you just try to push it. So that's generally tends to go from the distal strut. Otherwise, even if you're not doing like that, go to the main vessel, angulate the wire, and point it towards the branch. And once coming back, the one which falls is generally the distal cell, is it not? Generally, while coming back on the pointed distal, wherever it is a resistance flow, it goes. Then that's where you push the wire in and cross the distal cell. You have to be very definite whether it is distal or proximal. You can image with OCT and then find out exactly. But you also get a reasonable idea by angiogram by seeing the where the wires are crossed. But sometimes in three-dimensionally it could look different. But by and large, we want to do this. Why? Now the reason. How to cross distal cell, I have told now. And the reasoning why distal cell is preferred provisionally is, if you see this, when you're crossing like this is the portion which I have dark with the dark red marker I kept. This, what will happen when you take the balloon, this is the example of balloon which I did. You have taken the balloon over it and then expanded this to this. Then what will happen? This portion of the stent will get shifted to this side, carinal side. So what is happening? The osteal disease which is there in the proximal portion of the stent tends to get covered. So it may not be covering this side totally, but it will get covered like this. If you imagine the three-dimensionally, it will get covered like 3/4 of the ostium could get covered by the stent struts. So it is like not the stenting of the main vessel alone, but you're also stenting the ostium of the side branch. That means the ostium of the side branch alone, which has a disease, also is stented. So with no extra metal. And there is another advantage is there's no layers of stent struts across the branch, across the origin of this branch. So branch is free. The bridge formation, the fibrosis which could happen leading to osteal stenosis, that is also not there. So there are two important reasons why the provisional stents do well. One, it is not only the main vessel stenting, but main vessel plus the osteal stenting of the side branch. Two, there is no struts across the side branch. And part of this very minimal thing happens on the other side, because generally balloon tends to go in this direction. Obviously, unless you push it towards the other side, balloon won't injure the opposite side. This may not happen much here. So this stent struts gets covered here. This is about a distal strut crossing, which is recommended in the provisional stent. Now I'll tell you about proximal stent cross. Proximal strut crossing actually was initially preferred in DK crush and other things. Wherever you are planning to put a second stent, is basically you just imagine a situation where there is one or two struts left here in spite of you putting in that this could obstruct the flow of the stent. So concept was when you can dilate it anyway, you're covering this portion with another stent. So it doesn't really matter if there's no stent strut here. So people said you can cross it proximally and then take the balloon, and then stents also go easily. And then stent anyway will protrude little, and then you cover it up with a final kissing balloon. It doesn't really matter. That's how the proximal stent strut was preferred in it. But even then, even the distal stent strut crossing also with the thin stent struts, it doesn't matter in today's era. So I hope this is very clear. This doubt, confusion should not be there for all those who are attending this class in future. I wanted to make it clear. So the reasons, the reasoning, what you mentioned, angulation, all that is fine. The philosophy behind is this: newer kernel angle creation, then decay crush methods. What all techniques? That's all fine. But idea is to have a proximal, at least ostium of the side branch covered with a stent, and also opening of the side branch to be free from any stent struts. That is the basic mechanism by which the provisional stent does it well. Okay. Hope this is clear. Then I'll proceed further. Then we'll come to the tips and tricks of some balloons. Then balloons, appropriate size balloons should be used. If there's no point, if you take very grossly undersized small balloon for the side branch dilatation, the side branch is 2.5, it's okay if you take 2 or 2.25 balloon. But if you inflate it with 1.5 balloon, hardly does any good. So probably only little undersizing is okay, but definitely don't oversize. If you oversize it, you will definitely produce dissections, and it will always end up with the two stents. So probably you can undersize by a quarter. and the maximum should not cross the size optimal. Preferably, again, end balloons, especially when crossing the main vessel stent struts and going to the side branch, always better to take new balloon, because old balloons which have shoulders all around could damage the stent struts. So always take new balloons, and very difficulty even it won't enter because the profiles changes. So to cross the main vessel stent, always you take the help of, if you have to conserve the balloon, so the only place where you can definitely open end balloon is to cross the main vessel stent strut. And then look for any resistance at the entry point itself, not going into the bifurcation only. Entry point itself, the resistance means probably wire, when you're wiring, inadvertently could have gone through the stent struts. So you need to be careful. Or sometimes you also get into this crisscrossing of the wires, wire entanglement, that also need to be seen. And probably if you analyze what is happening, where the balloon is getting stuck, you'll know clearly what is the point where, what is the trouble which is causing. Okay. And other point which needs to be taken care is when you are doing a bifurcation type of thing, even don't extend the proximal portion of the balloon too much into the main vessel, which is unlikely to be covered by a stent. So you need to keep that also in mind. So if the lesion is there in the proximal portion of the main vessel, that's okay, even if stent expands. But if the lesion is not there, don't get the balloons too much proximally. Sometimes when you're seeing only in the cranial views, if you see the caudal views, it could come very close to left main also sometimes. We need to be careful. Always check the proximal portion of the balloons, where till what level they have reached in the caudal views. Never position too proximally the main vessel, which is unlikely to be covered by a stent. That's what I mentioned. And always, again, positioning too distally in the side branch also leads to dissections there, and we may not cover with the stent, and that is also need to be kept in mind. And probably, I always felt that for doing a final kissing balloon could help, and I will show you the data for it, and also probably part. Then which type, this concept, I think many of you are familiar now, this Murray's law or Dimmott's law, what you said, is basically when you're taking the two balloons, 3.5, the proximal will be 2/3 of these two. That means 4.36. So the 2/3 of these 3.5 will be 4.3. That's how you select the balloons when you're selecting the balloons. And this is the part technique is important now. What the concept which is coming up is, once you put the balloon, put a stent across, what we do is, there is a, if you have taken this vessel, this size, suppose 4, this is 3, we tend to take the stent depending upon the distal diameter of the balloon. Otherwise, you'll dissect here. So 3 stent will expand at the most to 3, and there will be some space left here, if you see this clear. So we need to oppose the stent well here, number one. But at the same time, we also need to not get this, again, the proximal optimizing balloon into the distal vessel, because again, the entire thing will be lost. So exactly, the balloon should be positioned in this way, as it is shown, and the struts of these also get opened up. Sometimes the flow in the side branch also improves once you do a pot. So take a bigger sized balloon, which is optimal for the proximal vessel, and see that that is short enough, but at the same time, it is not too long to come into the distal vessel again after the bifurcation. But it has to cross the bifurcation point, somewhere come into the middle part of the side branch. If it is just coming only till here, not, that is again not, I have made a cartoon out of it. So you see this now. If you position the stent like this, that's okay. The proximal balloon should come into this right, tick mark is right. It has to come till here. It is definitely should cover, the size should be appropriate to the proximal vessel. So the length should come at least till here. If it goes beyond, again, it is a problem. So this, again, there's a chance to get distortion of stents. And somewhere in between is acceptable, but what is acceptable, correct thing is here, so that the proximal thing gets cleared and the struts are opened for the side branch. Then we go on to stents. By and large, this discussion was there before the regulating stents. Now the TES has proven beyond point of superior to BMS. So there is no doubt to consider DES. Stents with open cell design are good for side branch access and preferable. I think last time when I was discussing the stent pharmacology stent selection, I did explain to you what is open cell and what is closed cell. Open cell gives a free access for the side branch access. That's why stents with open cell design are preferable. And appropriate size diameters depending upon distal vessel. And take lengths to have some portion of the stent proximal to both branch origins, because we need to do kissing and pot. So if there is no stent left proximal to it, then again, sometimes we could develop dissections proximal to the main vessel stenting. So you need to have significant portion, at least about 8 mm, to place the balloon later. And then provisional stent preferable, and always that is what as the data showed. But whenever you have a side branch problem, big side branch, or side branch gets occluded, don't hesitate to use a second stent. But one thing we need to keep in mind is stents do not like bends. When there's acute side branch bend, you need to tackle the side branch first before the main branch. So this should be kept in mind. Stents with the marker starting at the stent position, like signs what is there we see, is preferable, especially in the ostial location placement. Which stent? Probably whichever stent you're comfortable with, you can continue to use it. But probably Endeavor platforms, now Resolute Onyx platforms, has a maximum open cell diameters, which is shown here is 6.3, which is generally preferred. And the Synergy also is likely to have similar things. And you also need to keep this expansion characteristics of the stent in mind, because when you're expanding the stent proximally, what size stent you're expanding, what the maximum expansion limits of that stent you need to know. So 2.5 stent, the maximum expansion limit is 4.4. If you have to take it up to 5, probably you can't take 2.75. You have to take something more bigger than 3.5. All of us, I have said in the stent pharmacology talk also, keep this chart in your cath labs so that you will know the expansion limits of the stents. Now, single stents versus two stents, many of us thought that two stents give good appearance, but studies were showing the other way, because problems were more with two stent strategies. Procedures would become complicated. That's why we always said provisional stent strategy is better. Type of stents, there are different types of stents. Main vessel stents, bifurcation, we have an access to side branch. Sometimes you have a different type of action. Access type of stent, there you put it in the main vessel, and the both branches can be accessed. And the dedicated bifurcation stent, I will show one example where you have a main vessel and you have always access maintained, or a capella type of stent where this is only for side branch and the ostium of it gets stented. Then you can again take main vessel stent. These are different types of dedicated bifurcation stents. So coming to the stent techniques which are used, so basically provisional stenting is by and large 70% of the cases it is being used. And about 25-30% of the cases, probably you could use two stents technique depending upon the anatomy. And by and large, what a stenting technique you are comfortable with, you can use it. But what is now preferred is the thin stent struts. Now, BBC trial which came showed that we were all fancied about mini tap and tap, which compared tap with culotte. Then culotte did better because less of events on the side branch. But we always still are not very comfortable in having two layers of stents in culotte. So we tend to do the mini crush tap techniques by and large. But if you're in the process of avoiding, don't miss the ostium of the branch. That again leads to problems. So if you are not comfortable, not very confident with the angulation, probably culotte type is also okay, but don't miss the ostium. Then this, depending upon the anatomy, what is shown here, V stenting or T stenting is what is recommended. This is especially followed in left mains, where LED diagonal bifurcations, probably mini crush or tab, what we call, is preferred in this stent technique options. Which MADS classification is basically depending upon the stent which you put first. This is given. That again decides depending upon the anatomy of the vessel. Generally, by and large, we tend to follow this type of thing where main vessel stenting is done first, and then access the branch to side branch and do a provisional stent with the Cushing balloons. So, but sometimes if the angulation is very acute, where the stent is difficult for it to be passed, you might do the side branch stent first and then do the main vessel. This is very rare, but depending upon the very tortuous anatomy or angulation is extreme, sometimes we may do it. And when the side branch is also big, especially when your left main bifurcations is always a different ball game. We'll discuss that further in the left main stenting in the next class. Then final kissing, I always said this, final kissing is important. Whenever final kissing is done, then probably patients have less of immediate problems and less of restenosis. Main vessel, if you see, main vessel also restenosis rates were higher with no kissing balloon. And side branch, especially when the main without kissing, has very high, significant restenosis rates are very high in side branch without final kissing. This became statistically also significant in one of these trials. So we feel somehow, if it's possible, always try to do a kissing balloon. I think these are the basic philosophy, principles, and what I tried to explain. And I would take you further through some case examples and cases, and also try to show you a LED diagonal live in a box case, and show you in the end with a dedicated bifurcation stent case. Some chat question came. I'm happy. I'll try to open that. Dr. Ramya, sir, what sizes and how much pressure should be used during final kissing? That is again depending upon that Murray's law, what you are using. 2/3 of the proximal position, keeping on the distal balloon sizes. That helps even in here, even in this. But at least nominal pressures have to be used. But if you still feel the stent strut at the origin is not expanded fully, whatever appearances you feel it in angio, you could still go up further. What is also important is how you are deflating the pressures. So always try to deflate the side branch first and then the main branch later, because again you tend to have no business to distort the main vessel, because main vessel is the most important. So not only the size, inflation styles, not only the pressures, but how we are deflating also could matter. And always allow the balloons to deflate totally before you pull out, because again before the balloons are deflated totally, if you again try to get that stents back, then probably that could also distort the stent anatomy. So that's important thing. And dilution of contrast also becomes important. If contrast is too much thick, then it takes a while for the balloons to deflate. And when you're pulling it back, the guide catheters also tend to get sucked in. These are the important precautions we should do. And always see in the proximal positioning, apicaudal view, where you're positioned proximally the stents or the balloons. It's a very good question, Ramya. Thank you. Now we'll go to the case examples. Hope these angio pictures play. Sometimes they are it's fortunate that they're playing. I did again till the last moment that it's not playing. Then I did some adjustments. Finally, hopefully, it is playing now. If you see here, this is on middle-aged female who came with a very tight mid-LAD, and probably there is a tight diagonal disease. So in this, now the LAD size, diagonal size is big, but osteal disease is there only at the ostium and maybe tight lesion. But if you don't do anything, it's likely to occlude. So what we did, we wired the both branches, and then we did the dilatation of the branch with a provisional balloon. The only worry comes here is if you are dilating, if the vessel dissects, then you will be left with no choice but for taking the second stent. That's how we need to optimally do not very high pressures, but nominal pressures and open up. For the sake of time, I couldn't get all the things. And then we did a main vessel, after the balloon dilatation, we did a main vessel stent. And then after that, we are doing a final kissing. The appropriate balloon size has to be taken, and see that both of these balloons are there within the proximal stent. And they did a final kissing. And then you see this is the final result, which has come up well. So its provisional stenting works well many other times. This is a live in a box case. I thought I would show you for interest's sake, and I can also relax a little when this is coming, when I am talking it in the live in the cath lab. So just watch this. This is my colleague, Dr.
We have selected a 61-year-old gentleman, hypertensive, diabetic, in recent ACS, and suffered an anterior non-PMI anthrocephalemia on 12th of this month, and has ongoing angina on and off. His diagnostic angiogram was done by Dr. Ravindra Reddy, my colleague at Fatima Medical College. And then for this bifurcation stenting, patient was shifted to our place. We'll see today's pictures. Yeah, good morning. So you see today's angiogram pictures. Because we planned for a bifurcation 2-stent technique, it is better to take 7 French guide, femoral root, and then we have engaged it with XB3 catheter. And this is the RAO caudal picture. Shows left main bifurcating into LCX and LAD. Next. This is the cranial view, which shows very critical stenosis, almost subtotal occlusion of mid-LAD. If you observe carefully, there is also a tight osteal disease in that second diagonal, which is a big diagonal. Show the RAO cranial. Next. This view again shows it clearly. Very critical stenosis in the middle LAD, tight stenosis at the origin of diagonal. If you observe carefully, right from the diagonal origin to the critical stenosis, LAD has a normal segment is just proximal to the origin of the diagonal. That's where we intend to start our stents. And then there's again back of that hump, there seems to be mild disease extending onto the ostium, but we'll see how it goes. Then we have our aim is to do stents in a double case.
Then here,
if you see here, we have wired both LED and diagonal, and LED flow is already less. So we intend to dilate the LED first at the critical stenosis point, and then put the stent into the diagonal with the positioning of balloon at that point in LED to avoid too much protrusion of the stent into LED. And this is how, after the wiring, wire crossed reasonably okay. And then there was some trouble in the tortuosity of the diagonal, but we could. 9 balloon and pre-dilating the LED. Balloon crossed easily, suggesting it is an ACS type of lesion. And we're just taking it proximally, again slightly dilating it here. Okay. 9 balloon and pre-dilating the LED. If you see there, after the dilatation with a small 2 mm balloon, now the flow in LED is restored and patient's pain is less. And if you see, observe it carefully, there is some disease, appears to be mild disease, could be spasm at the bend also. But we'll go with the original plan of taking up stent up to that hump, the proximally just up to the small twig, and we'll get it back proximal to the diagonal and that hump, which is better seen in the caudal views. And
so here actually there's some sound issue. The stent is taken into the side branch, and then the proximal protruding portion, we have taken a balloon and we are occluding it. And that's how the side branch is stented first, and the protrusion too much off into the main vessel should be.
What we did is we took a second wire and went into LED. Now I'm getting the LED wire back and LED wire back and trying to get that LED wire into the diagonal so that you're absolutely sure that it goes into the lumen. So there is some initial thing, then it crossed. Ideally, you're supposed to cross from, if possible, from the distal stent strut. But I think I'm almost certain that it went through the LED lumen, now through the lumen into the diagonal. Thank you.
Then we also then did a another stent in the left lumen.
Hemodynamics.
This is the final result, starting pre and the post. So hemodynamics also was good, and patient had a good result. The LED diagonal both flowing well, and you hardly can make out where's the lesion. That's the beauty of the latest generation stent. This is another patient where a very tight stenosis in the LED, critical stenosis there. And at the same time, that point only, this is actually another live case which you did to some conference. I took it up, and I'm avoiding the live block, it takes more time. And the angulations always need to be checked in elevocranium. And then this is a stent balloon pre-dilated, then stent is taken in. If you see before the main vessel stent, you already passed the side vessel stent into the side branch, and then there's some disturbance because of light interfering here. And what we did is we inflated the stent there. We're also inflating the main vessel stent, and we did a lot of pictures for sake of time. This is a good result. Finally, this disturbance coming not from this, I think it's coming through some other Zoom mics being on. Please mute the mics. This is another case where you had a LCX lesion with a long disease in LCX as well as in the OM branch, and I'll take you through the steps of it. And we dilated this before with a bigger balloon, and we also dilate this branch. Then the beauty of this dedicated bifurcation stent is you have markers on it where you have to place this marker of the origin, you know it, and that's the point where you have access for the always access of the side branch is maintained with this bifurcation stent. So you need to take it like that, and unless the lesion is prepared well, this is a little bulky, it doesn't track well. This is, I did a live transmission, another conference again. This is an Nile pack stent. We take the stent there, and then probably once the stent is inflated, you also inflate the side branch balloon like that. So this is where both the stent is inflated, side branch is inflated. Then you have an free access for the another stent to be taken to the side branch. Then this stent is deployed here. Another stent is being taken into the OM branch, and now you are inflating that, and you do a final kissing, and then you do a final kissing. Then you see this. It was before like this, and after that, I think it plays. After the dedicated bifurcation stent, then you see the final result is quite good. So this is the beauty of this dedicated stents is basically access to the side branch is always preserved and you get a good result. Initially, the stent was actually non-DES platform. Now they changed the paclitaxel. It was had a little more restenosis. Now they're coming with DES platform. I think we have crossed 1 hour. We can have some discussion. The preferred strategy, what is required in bifurcation lesions is obviously DES is a stent of choice. Then no single strategy works for all bifurcations. We need to take decisions depending upon the plaque extent, size and extent of the disease in the side branch and its angulation. By and large, we understood that 111 will be more difficult ones to treat, especially with the bigger side branch. Majority of the bifurcations, we can apply a single stent strategy with provisional side branch stenting. However, when there is significant large caliber of vessels and bends, the probably side branch can be addressed first. If you think that two-stent strategy is reasonable and important, then probably do it. If you need two stent implants, implant two stent. If the result is good, immediately the follow-up results will be favorable. But one thing we need to keep it in mind is treatment bifurcation is with the provisional conventional stenting, but we need to keep it swift and simple. Don't be dogmatic but pragmatic. Don't aim for a very perfect result, but always where there is doubt, try to do imaging and try to sort out the issues. Unfortunately, I thought I covered it in the imaging session. I didn't show the origin of a side branch, how it is imaged and all. I showed it in the OCT imaging class before sessions, which we discussed before. That's why I didn't get it here. But you have now good mechanisms to see whether starts are covered, no osteal miss, all that with the imaging. I think with this, I think we can close the session and we want to have some 10-15 minutes of chat discussion. Can we make, I'll close this and can we have a gallery view, please? Thank you very much. Hope all of you had some good learnings from this, and I tried to make some of the points which are always confusing regarding stud crossage and type of stent platforms to be used, and then how do you use dedicated bifurcation stent, things like that. And I'd be happy to take any questions. Can we have chat questions coming up? Yeah, now I have a gallery view. I can see everybody, whoever it is, who is participating it. I see a lot of known names. I'm happy that all of you are logging in with good interest. And can we have some chat questions now? I see Dr. Ravinder Reddy also logged in. I'm happy. Ravinder, I showed that case which you sent some time back. We did one live transmission. I think it's a great coordination and cooperation from all the teammates that gives strength. And to do any live cases, sometimes we suddenly need a difficult type of case. All of you are there. That's how we could do many of these cases, live transmission and other things. And I thank all my colleagues for making this possible. And hope I've cleared some of the doubts of bifurcation. Anything else which you people wanted, expected, which is missed out? Left main bifurcation, I wantedly avoided it because the left session is the left main. So left main crossover, when do stent, osteal, all that problems of left main bifurcation, left main, I will deal it in the next session. And I also wanted to inform you that I wanted to make these sessions more interesting. So I wanted whoever is best in the particular fields also to be coming in, probably along with me. So that way I discussed with Micro also. Maybe next left main session I will take it. But later on, CTOs, structural heart, and other things, I'll involve my colleagues like Dr. Sushil Kodali or CTO Dimitri, whoever is the best in the world, probably would come into the sessions. I request all of you to take a note of this and take it more seriously. And what all doubts you have in CTO, Dimitri is the Columbia University faculty. He's a director for CTO interventions. He will be there with us. And though it's not a huge meeting, generally he is the director for that CRF CTO Connect meeting, which recently happened. And is extremely good operator and a good friend of us. That's why we agreed to be there. And Sushil Ajay also will be there in subsequent sessions. So I request all of you to take it more seriously, communicate this to all your colleagues, and participate actively. And but for the left main crossovers, other things, any other questions, I'd be happy to take here. I've got some question from Dr. Naveen. Sir, after a provisional main branch stenting, does side branch FFR help in significance of lesion? Yes, that's a very important question. That's what I did mention. Basically, after you stent a vessel across the main vessel, the side branch, though it might look little pinched, but by and large, the flow pattern is maintained well. Then that little pinching appearance and angiography will be still okay. And then probably if you do FFR, then it will come negative. Then you leave it. This is more useful, especially in left main bifurcation when you're stenting across LCX, because you can't afford to take leave LCX ostium, which is bigger. So, but even in LAD diagonal, sometimes when there's a pinching of the vessel, you take the help of FFR and FFR comes negative, you can reasonably leave it. But what will happen is a new lesion was not there before. Suddenly it appears after main vessel stenting. That's where this only angiographic pinching of the appearance comes and FFR will come negative. But before stenting itself, there is about 50-60% of lesion. After stent, that sometimes could be more. That's where I think FFR is also likely to be positive. So before branch did not have a disease, but afterwards you have slight pinching. That's where I think you can leave it. And usually if you do FFR also, it will come negative. Suresh Kumar, main branch stenting, side branch ballooning, good dilatation of side branch. Do we need to stent side branch? That's a good question. Basically, that's what we were discussing. The provisional stent approach is what you are telling. So main vessel stenting with side branch ballooning. That is that will make the struts of the side branch covered with a few struts of the stent. That's how. I think you can chat because too many confusion. A lot of mic echo is happening. Okay, and then Dr. Suresh, I hope I've answered. That is what is the provisional stent. You do balloon dilatation, but see that you don't do very high pressure balloon dilatation, and see that you don't produce distal dissections in the side branch. And that's where I think just nominal atmosphere inflations. And there's one more type of dilatations which is described, which is basically like when you're very low pressure atmosphere dilatation, just to open up the stent strut, not to cause too much damage in the side. With previous stents that was being more done. And but even otherwise also LCX ostium, you're supposed to, when there's no disease in the LCX the branch, you tend to do that. And Vinod Babu says when to stent pinched vessel. Yeah, that's the thing. That's where the discussion and our experience goes. Just don't go by angiographic pinching appearance. You see whether the flow is good or not. Significant stenosis happened, or plaque protrusion happened, or dissection happened to the branch, then the flows decrease. When the TIMI flow is not 3 and it is to 2 or 1, then that is a time where probably we need to take the help of second stent. But the flows are good, even though lesion is looking little more, also we tend to leave it. If you still have a doubt whether to do it or not, you take the FFR wire help and do FFR. If FFR comes negative, you can leave it. But mind you, FFR doing in the side branch is not easy. FFR wire is stiffer, and the process of going into it, sometimes you could injure the vessel ostium also. So keep that in mind and don't force the FFR wires into the branches. But if you can do it well, easily, then probably you can do it. And angiographic just pinching appearance should not make you decide for another stent. I think I see Dr. Trupti Madam also always very senior to me, but always.
I want to ask one question, Dr. Sreenivas.
Yeah, please.
Actually, I joined very late. I missed your initial all the strategies for the different types of bifurcation stenting. I have a doubt because in last European Society of Bifurcation Stent, the discussion was that we should not do pot always the final pot after the final kissing. After the final kissing in 2 stent strategy, do we have to do the pot exclusively always as a final point, or it may distort the final kissing, the stent, opposition and all, the distort the stent. So is it recommended still, or it is now they say, if you think final pot is required, otherwise we may just leave the final kissing for the 2 stent strategy?
I think what was that is how the continuing medical education and updating ourselves becomes important. As latest as 1 week back, OCT guided study which came in one group, they did part final And other group, the final part was not done. Only kissing was done. So the first part is there. The final part we are talking. What you're asking is, after the kissing balloon, shall we do the final part or not? That's the question. Initial concept was in the Europe PCR also everywhere. The European Bifurcation Club also proposed that you need to finally optimize the proximal portion of the main vessel by doing a part, because it's very important not to have any inadequacies in the main vessel. But this latest study, which came out with the OCT guidance, did not distinguish in between the two approaches, whether final part done or not. That's how I think we need to have our own clinical decision-making power. And after doing a kissing, if you feel the proximal vessel still looks a little under, and then probably it needs a little work, then probably you take a little bigger again proximally part. But my gut feeling is it's better to do it, because you cannot have any inadequacies in the proximal portion, proximal to the stent. Once you put the balloons are coming reasonably back, almost up to the branch, almost up to the proximal start of the stent, then it's okay. It's almost like doing a part. If you have done a kissing with only till the origin of the branches, and significant portion of the left main or main vessel stent is left out, I feel then doing a proximal part is okay. But if you want to avoid a proximal part, if the balloons have come almost up to the proximal portion of the main vessel stent, then even if you don't do it, it may okay. That's why in that randomized study, when they did it, you can't exactly control everything in that randomized trial. It did not show difference. But finally, when there is any doubt, do imaging and see the areas obtained, see how the branches of origins are there, and then take a final call if there's still ambiguity.
Thank you so much. Thank you.
Dr. Krishna, don't think all other colleagues, don't think Madam doesn't know. She knows everything. Even she knows the procedures also. She'll allow juniors to keep doing it. And when there's a problem, she'll come in and take over and do everything. Here also, just to encourage me, she keeps asking. She knows everything. Anyway, from Dr. Krishna Sareen is asking, provisional strategy converted to two-stent strategy due to side branch compromise. If the angle is less than 70, what the technique to use to place the side branch? This is a good question. Basically, you thought you will get away with provisional strategy, but in between, you had a side branch vessel compromise. That's where the flow decreased or something happened because of defection. Then you have to take a second stent. What technique we need to follow? That's the question she's asking. So, Dr. Krishna, maybe male, I don't know. He's asking, basically, if the angle is less than 70, what technique to use on the side branch stent? So, that's what we mentioned in that diagram I showed. If the angle is more than 70 or up to 90, use just T type of stenting. If the angle is less than 70, then probably people have recommended culotte or other various types of stents. Why? What is the reason to stent this? Again, select this. It's not fancy. You should not miss out the ostium of one side again when you're doing it. When you're putting a stent like this, if it is 90, that means definitely both sides will be covered. But if the angle is more acute, if you're putting like this, one portion of here of the ostium could be missed out. That's where people recommend directly going in and doing a culotte proximally. I think, hope you understood this concept. When the angle is extremely narrow, when you are coming more deep in with a mini tap or minimal protrusion or mini crush, whatever you want to do, one side it comes more. So you'll always worry to go more in. If you don't go more in, then other side on the top, you'll miss the stent. There won't be a stent there at that ostium. So that's where culotte scores in this type of things, because you come inside and directly do a proper thing, then again dilate proximally with culotte. So there's no question of missing one side of a ostium. Whereas if it is 90 degrees, there's no problem. If you do T stenting, it can exactly come, ostium won't be missing, and you can do just a T type of stenting for the side branch. That's how the importance of angulation. I think when you understand the concept why the recommendations come, then there's no confusion. So now I think not to miss out the ostium, if the angulation is narrow, probably you need to go with culotte type of thing. But if you're too concerned about too much of metal, then you do a mini crush, but see that the both types of things are covered. Whereas if it's 90 degrees, where there is no problem of coverage of ostium on both the sides, you can do T stent. Hope I've answered that. Is it clear, Dr. Krishna? Any further questions or comments? Yes, sir. Thank you, Krishna. Any other questions? We have 5-10 minutes left if you want. Anybody, not only on bifurcation, if you have any other issues, anything you faced in the labs in the last month, you can feel free to exchange thoughts and ideas. Of late, I request all of you to be more careful. COVID cases are increasing these last 2-3 days. I think your case number load has gone up. All the hospitals are picking up busy. And I wish all of you have taken vaccine. From Ramakrishna Janapati, my colleague to everyone, what, sir, your favorite bifurcation technique? I somehow, the bifurcation technique should be different from left main for the left main vessel versus LED diagonal or OM LCX, I feel. This is again important concept, what I wanted to highlight after the next class of left main. Left main bifurcation is left main bifurcation is not a bifurcation. Actually, it is almost like two stents, two vessels, because left main is big and LED is also important, LCX is also important, both at the ostial locations. There, you cannot afford to produce any sort of nuisances. Your result has to be perfect. But even if you take extra stress and strain, the left main bifurcation, you have to have both stent struts done very well. That's where DK crush scores in the left main. But suppose the left main also, LCX is not very big, and then that's how people say, if the LCX is not left dominant and LCX is relatively small, RCA is big, then their LCX becomes branch-like. That all are for LCX OM branches or LED diagonal branches. This applies what I'm telling. DK crush is a little cumbersome technique, doing extra steps, extra radiation. Sometimes you could have troubles while getting the balloons back and all that. If you go distally, the proximal portions, less trouble. Please understand this concept also. DK crush, if you're doing left main, the chance of getting in trouble is also less because you're not going too deep in with the balloons and not exchanging back and forth. Unless if your bifurcation is very distal, mid LED or proximal LED or the OMs where you're going in and out, there's more chance of getting into trouble proximally. So there you find a mini tap or mini crush is okay there, because our idea is to avoid 2 layers of stents. That generally, we were not favoring culotte before, especially in the earlier era of thick stent struts, because Cypher taxes which are thick struts, then obviously when the thick struts, 2 layers of strut come in the proximal vessel, the chances of thrombosis and under expansion of stents and restenosis could be more. That's how we were not liking culotte before. But the BBC2 trial showed other thing, and the bifurcation, not the left main bifurcation, please. LED diagonal, OM bifurcation or PDA PLV bifurcations. Culotte showed better results there. The side branch, sometimes you could miss out by mini crush or tap techniques, what it is. But still, personally, we tend to do more tap or a mini tap or mini crush type of things in LED diagonal OM type of side branches. Though data showed that culotte is best, especially with thin stent struts. The culotte, the advantage is no way they are missing out the ostium of the side branch. You definitely cover everything. But what I feel is the stent struts, ostium, open cells also have 4 mm gaps in between. Even if one thing is less, still I feel mini tap could be okay. So to answer the question, left main bifurcations, DK crush, LED diagonal bifurcation, OMs, so probably whichever technique you're comfortable with, a mini tap, a mini crush, or a tap technique is what is required. But if the angulation is more than 90, it is less likely in branches distally. Always LED diagonals will not have 90 degrees angle. OMs also will not have 90 degrees angle. They'll have less than 70. They're probably minimal protrusion and opposition technique like tap technique and mini tap, mini crush techniques are okay. I think this is another important point which is raised by Ramakrishnan. Thank you. Any other problems which any of colleagues faced when we are using 2 stents? Don't tell me that nobody faced any problem. It's not possible. If you're done number, at least some stent numbers with 2 stents, they obviously you tend to get into some troubles. Okay. So did any of you find you put 2 stents proximally, that when you did a epicaudal view, you had a proximal vessel dissection? Anybody notice that? All of you in a hurry to go? Okay, and then I'll also close. But what I'm trying to highlight is always check the proximal extents of the stents, balloons, which you're doing. When you're doing in your enthusiasm to do a proper kiss, if you don't check till what extent the balloons are coming proximally, the balloons could tend to come out from the proximal portion of the main vessel stent, and you could produce dissection proximal to the main vessel stent. And that's where you need to take a extra stent proximally. It did happen to us. So always check proximal portion of the stent, number one. Number two, if you have very minimal stent portion left in the proximal portion, again, the balloon is not available to do a part, then you'll be helpless. Sometimes you'll take in bigger balloons and the balloon will go on to the extent of the branch again after the bifurcation. Those are the areas you could get into trouble. So that's where, again, you need to be careful. So optimal part technique to do part, you need to have optimal sized shorter balloons. That also you need to check, plan the procedure before. Any other questions? Dr. Chandramohan, Dr. Rajshekar Reddy? I think if there is possibility of opening up of cameras, whoever can do it, it is better. At least we can see each other. Is it possible, Vignesh? They can open the camera?
Sir. Yeah, they can, sir. They can unmute and they can on their video as well.
At least unmuting and asking everybody talking at once is going to some trouble. Let them open their cameras. Request all of you to open your cameras if you're listening to me. So any other, not only the questions or doubts, if any other ways you want this to be modulated, if it is going according to your expectations, anything needs to be done, I think you can feel free to tell me. I think it is 1 hour, 20 minutes, so we can actually stop it if there's no further thing. Anybody has opened the camera? No? Yeah, some of them have so opened the camera, so I'm happy. Then once you open the camera, I could ask also to ask something. So Krishna is already asked. Dr. Aditya Bajaj, any question? Dr. Kumar, Dr. Vinod Babu, I think he already asked. Mohammad Hidayat. Good. Anything, I don't know. I try to make it a little interesting by showing some live in a box case, some case presentations in between. So I'm telling you some important concepts I always want to imprint in your brain rather than just didactic talk. And that's how I try to spend a little more time there. But if you have anything else in your minds or brains, so then feel free to not only now, or you can text me in the chat, in the WhatsApp group or separately also. I'd be happy. And that's how I think commonly we could always improve upon each session. We do it, we can always improve further. Thank you. If there are no further questions or comments, then we will close. And next, Vignesh, next session would be in the same month, no? That's what you people mentioned. The last.
Yes, sir. Last Saturday of this month. That is 24th.
24th April, we have important session on left main interventions, where the crossover stenting and all other things, again, image guidance and data and things like that, I will be reviewing, showing the important case examples also. And now another important area where we conquered and almost took it over for surgeons is left main. I will be covering that. And then probably another important area of left main bifurcation, where the osteal LCX, that is the main difficult animal which we are yet to conquer in interventional cardiology. Regarding that also, we will discuss and then try to show some live case if possible, live in a box case, and we'll have some good discussion also. Thank you for patience.